Hi, and welcome back to Two Guys in Scrubs. We are Two Guys in Scrubs. I'm Silas Rades.
And I'm Delbert Yip. We're second year medical students at the University of British Columbia, and we started this podcast to share what it's like going through medical school, discuss medicine, and pretty much anything else.
Please be advised, Two Guys in Scrubs is for educational and entertainment purposes only, and the views expressed do not reflect the views of our program or our supervisors, of which we love both very much.
Yes. So 2026, first episode. I guess
episode of 2026.
Yeah.
Episode number 5. Welcome back. I'm really excited to be talking to you again and sharing with our listeners.
Same here. And how has the last month or so been for you?
So I've been pretty good. Thanks for asking. We had a nice long 1 month break, which was a bit of mercy on us, which was fantastic. Although unfortunately, I was fighting some kind of virus for at least it took me 3 weeks to now start feeling normal, which I've never had ever. And I didn't go to the doctor. I didn't have anything diagnosed, but the symptoms felt very viral. I never got so sick that I was bedridden, etc. So that was nice, but just like constantly feeling 50% health for a few weeks, which was frustrating, but I still had a great break. I spent a lot of time with family, caught up on some research projects, and overall, no complaints. How are you doing?
I'm doing well. Very similar, except for I wasn't sick. And in fact,
you dodged it.
Yes. Maybe because I don't go out. I'm basically self-quarantining. It's COVID at home for me every day. But I think I was also quite productive. In terms of research, one of the things I realized and I didn't expect to be so difficult is just getting access to all the different administrative portals that you need to just begin doing research. So of course there's the EMR, but then there's also just designing a clinical study. So there's something called REDCap that people use a lot in North America. I don't know about other places in the world. But in order to access REDCap, first you need a REDCap account, and then there's something else called REDCap Flex. And I didn't know that these were two separate things. So, I was just emailing different people every week to figure out what I needed to do, who I needed to talk to. And it ended up taking almost 2 months just to get everything sorted out. And luckily now that study is beginning to recruit patients and we can start collecting data. But the administrative part was an ordeal.
Well, congratulations on being past it. I know it can take forever to get these administrative tasks done in research. And I'm curious, did you also have to get clearance to access patient medical records, patient medical records?
Yeah, so that is going to be so basically my PI is going to I forgot what the technical term is, but she's just going to put certain patients into my scope on the on Cerner, which is our EMR. And so I'm not actually going to see all the patients, only the patients that are on our recruitment list.
Okay, that makes sense. I was also trying to get access to patient records for a project that still haven't got off the ground. But yeah, I found it's very hard, especially we're in second year now. In third year, we actually get access, like we get a login to the public health system. We can see public records. But when we're in second year, we're totally locked out. We don't have a login, so you have to get special permission if you're doing research projects, like it sounds like you are.
Yep.
Before moving on, would you be willing to share with us just a brief overview of the question that you're exploring? I'm quite interested.
Okay, yeah. So it hasn't really changed since we started this project last year. It has kind of evolved in terms of what we're looking at. But the main thing is there's this population of people with endometrial cancer who are either not responsive to surgery, or they can't undergo surgery. They're not eligible for it, or their disease is not amenable to surgical removal. Maybe it's metastatic, maybe it's too advanced, or maybe they have other contraindications. But normally surgery is the first line treatment for endometrial cancer because it is usually very responsive. And then the second line therapy would be systemic therapy. So chemotherapy is usually quite good, and this is usually platinum-based chemotherapy. there is a subset of patients.
Platinum like the element?
Yeah, platinum. So like cisplatin or paclitaxel, things like that. That's usually the regimen. So if you read oncology reports, sometimes they'll abbreviate it as C/P, something like that. So anyway, there's a subset of these patients who, either they didn't undergo surgery for whatever reason, they failed to respond to surgery, and or they didn't respond to systemic therapy. So we're looking at this really difficult to treat population with either advanced or recurrent disease. And we're trying to understand, who will respond best to immunotherapy, which is sort of this up and coming modality of treating difficult solid tumors. Solid tumors include things like melanoma, colorectal cancer, basically anything that's not blood, so like lymphoma or leukemia. And it's been shown that these immunotherapies work very well for these solid tumors. And the mechanism by which they work is by blocking this interaction called the programmed death ligand receptor axis, blah, blah, blah. So basically there is a receptor and a ligand, PD-1 and PD-L1 respectively. And by blocking this interaction, you can engage the body's own endogenous immune response to kill off the tumor cells. But it turns out that some people with these tumors, whether it's endometrial cancer or not, don't respond well, right? So for the majority of people with these types of cancers, immunotherapy does work, but then there's a population for which it doesn't work very well, and they either develop resistance, so they respond very well initially, and then they don't respond. Their disease continues to progress, or it relapses. Or there's some people who never respond at all, and they just keep progressing, and their symptoms keep getting worse. And so we're looking at this population of people where all lines of treatment don't necessarily work, but we're also just recruiting people who failed the first two lines of therapy, surgery and chemo, and trying to predict what will happen once they get immunotherapy by measuring different biomarkers. And right now it's like a really shotgun approach. We're just measuring all kinds of things that we could potentially think of as being useful. So like circulating tumor DNA, stool antigen, or not stool antigen. We're currently doing infectious disease.
You're jumping ahead to this upcoming week's material.
Yeah. Cool. Stool microbiome, so gut microbiome. We're doing measurements of that, and all kinds of things like histology. When the surgeons, if they've had a surgical biopsy before, we'll try and look at the tumor histology and do some advanced sequencing, next generation sequencing on it to look at the mutations in that tumor. And one of the interesting things is that a few years ago, a large group identified several molecular subtypes of endometrial cancer. And it turns out that some of these subtypes have prognostic significance. So if you are of a particular molecular subtype, if you have a particular set of mutations, then you will fare much better than another subtype. And we're trying to also correlate the response to immunotherapy with these known molecular subtypes. But it's not necessarily true that they will be correlated. We're starting to think that this is the case because I don't know if you remember what Lynch syndrome is, but Lynch syndrome ends up causing endometrial cancer in a lot of patients. So we're finding out that a lot of these patients who have defects in DNA mismatch repair, which is what Lynch syndrome is, may respond differently to other molecular subtypes that do not affect the mismatch repair pathway, or they may be like a spontaneous p53 mutation or something like that. So anyway, I just want to summarize. This is just trying to look for biomarkers that will help us predict and prognosticate for patients with advanced endometrial cancer who will receive immunotherapy. And so that will help us, better, manage these patients. And maybe in the future, if new therapies come on board, we can sort of triage and select medications a little bit better. But right now, it's really in the early stages. We just submitted ethics, I think last semester, and we're just beginning to recruit patients, as I mentioned earlier. Sorry, I think I was talking for like 10 minutes there, but hopefully
no,
that
it's
was
not a
okay.
problem at all. You know what? I would have interrupted you if I got bored, but that was extremely interesting. And yeah, I have a few things to say, but I think by, one, being earlier on in this kind of project and having a project that, has a specific question, but also is quite exploratory, if I'm understanding correctly, can be both very exciting. It's sometimes a little bit, I don't know, I don't want to say anxiety provoking, or you're you're worried that your research question isn't sharp enough because you're really just, like you said, it's a bit of a shotgun approach. But I think at the same time, this adds a layer of excitement to the project because you can't really predict what exciting findings that might come out of it. And
Exactly.
so I think that's enough to stay very engaged. And if I just a bit of a methodological question, which was, so will all the treatment arms, or all the different subgroups in the study, they'll all be receiving immunotherapy? It's just whether or not it's what kind of preceded the immunotherapy. Did they have surgery or not, etc.
Yep,
But
that's right.
all the groups will be
Yep.
receiving the
Yep.
immunotherapy. Okay, interesting. Well, you're gonna have to keep us posted right here on Two Guys in Scrubs about the
I don't know if
development of
I'm
the
allowed
study.
to do that.
That's actually true. Well, I hope you're allowed to divulge what you have already. I think that's not a secret at the moment, is it? No findings.
No, I don't think the study's been registered on like a major. You can find it on like BC Cancer's website, but it's not on like say what's it called, the NCBI, or National Cancer Registry for clinical trials.
Mm-hmm.
So it's going to be
Mm-hmm.
hard to find information about it. But it's a small study. I think the idea is, we run this study for maybe, I don't know, 60 to 100 people, and try to see what we get. If the results are promising, then we will either expand the study or design some more extensive follow-up study. And my PI has a lot of experience with big clinical trials.
Mm-hmm.
So I think that's the goal.
It sounds like a great experience. And on the topic of research, it reminded me of something that I wanted to ask you about. So I've been thinking recently about just the progression through medical school, and
Hmm.
after, the application to residency programs, and the competitiveness of residency programs, and
Oh,
the
yeah.
Canadian match system, or Canadian/American match system.
Yeah.
And kind of my question is around research. So we know in North America, at least, that if you wish to be a competitive or sufficiently competitive applicant to residency programs, you have to have some kind of research profile to your application. I think this is in part why the UBC Medicine allows us this extra time to work on research, and it even has a structured approach within the curriculum where we have to work on research projects. I think they're really looking after our development and our strength as candidates going into residency, which I really appreciate about the program.
Hmm.
But working on research projects necessarily takes away from time you can be studying medical foundational material, physiology, pathophysiology, etc. So I'm always wondering about this balance, because research, as you were alluding to, takes a lot of time. I feel like before I got into medical school, I had a short-term, like full-time research position, and I feel like I'm almost doing the same thing now or more, but also in medical school at the same time. And so I know I understand the value of research. Like the current modern medical practice is completely built upon medical research, and all of our guidelines and treatment pathways, et cetera, formed are formed based on what we know from medical research, clinical trials, and into gold standard evidence, like systematic reviews of well designed RCTs. So I understand the importance. It's very important to have research competency, to be able to read the literature, understand it, and even conduct your own studies. But it just takes so much time. I feel like if you want to be competitive, the amount of time you have to sacrifice just learning general foundational medical knowledge in lieu of running a clinical trial can be substantial. So I don't. My opinions are kind of emerging and always evolving around this topic and kind of how I feel about it. But I was just wondering if you have any reflections or thoughts on the topic.
Yeah, I mean, as you know, I've also been thinking pretty hard this semester about where I want to go and what I'm going to do with the rest of my time before we start clerkship, which is not many months away. So in terms of research, like I've always enjoyed research, and I even went to grad school before I started med school. And so, but maybe that's not been a good thing because my view of research is very almost Puritan. I feel my view of research is something you do wholeheartedly, full time, and but that's like basic science, right? So you do the experiments and it's iterative design. You're surrounded by people who only care about whatever they're working on. Whereas in medicine, I feel at least at the medical student level, it's really not like that. I don't think there are some people who are really gunning for something academic, and they're presenting at conferences, and they're maybe heading towards an MD PhD program. Some of the people in our cohort, but I think the vast majority of medical students, regardless of research background or not, they're just trying to go through the motions and get a few publications out. And to me, that's not like really the ideal type of research, right? But because the matching process is so competitive, it kind of forces you to do that. But the downside is, of course, it dilutes the quality of research that we get. And is there any benefit? Because yes, you develop some research skills, but what if instead you have people who just work on research that they're really passionate about that might not give them a publication in 2, 3, even 4 years time, but ends up being something really quite impactful. So a lot of PhD projects don't produce any publications until later on in their degree, and a lot of PhDs nowadays in the life sciences take like 4 to 6 years. A lot of my friends who started their PhDs in say like 2018, they're still in grad school for that reason. They're waiting for this, their big papers to get published, and it takes a long time to have these significant results ironed out. But yeah, I'm sort of on the fence because of my background, but I do like research and I want to continue doing it. I think I'm going to be more selective about the projects that I involve myself in. I do want to try doing things like case reports and things like that because I think they're just fun to read and write. But in terms of like, writing out a systematic report or two just to have my name on it, or publishing in no-name undergraduate journals or something like that, I don't think I'll spend time doing that, even if it's good for my CV or CARMS application. I don't know what you think about that.
Yeah, I think I've been asking myself a lot of the similar questions, and I really relate to a lot of what you said. I think we can ask this question of, or let me backtrack for a second. I think the concept of incentives is very important in almost in every aspect of life. For the medical students, it's going to be the incentives that feel imposed upon us just by the constraints of the system and the framework that we're working through, as well as our own incentives as we have based on our own interests, etc. And it's not a criticism of the system or the schools or the national match that there is an incentive to publish research, because I completely understand it's important. It's a good way to stratify students and assess them for their how hard they can work outside of school, their ability to ask important medical questions and follow it up with a study and present and publish, their ability to keep professional relationships with their supervisors and so on. It's all extremely important stuff. And so it's not a criticism that I think that we should just do away with all these incentives and constraints, because in the end we need to be able to compare students against each other, because the reality is there's limited spots in residency programs, etc. So I do understand it, but at the same time, everything has a trade-off. Everything in life has a trade-off. everything in medicine has a trade-off. And I think the trade-off of creating this incentive is exactly what you said, which is it can threaten the quality of research that's published. So, there's a buzzword these days, AI slop. I don't know if
Yes.
you've heard it. It's just
Well, I've seen
to
a lot of it,
describe
yeah.
to describe the overwhelming amount of material that gets created by AI and is posted online. Um, and I'm not I'm not saying that that medical research published by medical students going through medical school is the same as AI slop, but you could say there's this idea of research slop where it's hey, I'm not belittling all the research and saying that it's bad. But when the incentive is I need to publish, I need to finish before I apply to residency, you do create an incentive to maybe either cut corners or do projects that are not really of interest, but just because they are finishable, etc. And it doesn't encourage maybe this long-term, more inquisitive projects that won't yield such short-term results, but might arguably benefit the student more in the long term. But at the same time, that doesn't fall neatly into the ability to assess patients sorry, not patients, but students when it comes to applications. So it's all to say that there's a trade-off of everything. I'm not saying that I would have it differently, but it's interesting to notice the trade-offs that are created when we make these kind of decisions.
Yep, and that's the CARMS process has been going on for the last month or so, and some people have even gotten their decisions, like rejections and interview offers. Over the last week, I've seen a lot of fourth years practicing their interviews at the MSAC, which is our alumni building. And some of them are really stressed, some of them are taking it for fun and or just having fun with it. But overall, the message I'm getting is that you have to apply broadly, and there's a lot of disappointment. There's a lot of unexpected things that happen. So some people, they say you can take a year off if you don't match the first time, but when I looked at the statistics, it's like 10% of people don't match the first year and then they try again. And I remember seeing an article, and I might have even linked it to you, that it turns out that there are certain specialties where people just, are more likely to give up the first round to apply again to their chosen specialty. I don't remember. I think it was
I can imagine,
or ENT or something.
Yeah, imagine if you select just among the handful of most competitive specialties, that probably answers the question.
Yeah.
And I'd be wondering too, what percentage of students have not matched 2 years in a row and have gone on to apply a third year. That's a bit of a scary prospect, but
right.
I do understand people who really develop a passion towards a certain thing. It's very hard, and work for years in medical school with a dream of doing a particular specialty. They feel like they're contributing to the field, and they're really ready for that job, and to get rejected and then just to do something else. It's a really hard prospect to imagine. I can empathize. That could be a really hard decision, and it's not necessarily like that it's a cop out, because every medical discipline is important and valuable. But really, when you invested so much into something, it'd be very hard to accept something else.
Mm-hmm. And I of course our audience is somewhat non-existent, but I just want to address the fact that if it was a lay person listening to our conversation, they might have the criticism that why aren't we're taxpayers are funding a lot of our education, whether it is through the tuition, whether it is through student loans or bursaries and things like that. So why don't you just suck it up and go into family med or rural rotations and whatnot?
Or to say whatever you get.
Yeah, exactly.
Because in the end, you could say, in the end, the public could say, you are public servants.
Exactly.
We invest in you to serve society. You have an important role to kind of put yourself aside and serve the public.
Mm-hmm.
That's a completely valid position.
Yes. But on the other hand, you have people who say go into family med, and then they pivot their practice into doing mostly private stuff. That is one way to do things, and it doesn't have to be family med. It's just more common to be family med because there are more family medicine residents and
Yes.
doctors.
Yeah. And interestingly, though, I wanted to tell you something. Speaking of family med, so for people who know and people that don't know, well, I think everybody in Canada knows that there's a bit of a crisis in family medicine in general practice. I think this is a few years ago even explicitly stated by the Canadian Medical Association, and for decades they've been trying to develop strategies to address this problem. Only recently in the last few years, I forget exactly when it was implemented, but the payment structure for general practice and for family medicine doctors was drastically changed, resulting in a much more, many people would say, fair financial compensation for their work, as being one pillar of new incentives to try and increase the amount of medical students that want to go into family practice and go on to do longitudinal family care. And I was having a conversation with one of our tutors from last week during a communication session, and she was telling us that the competitiveness for family medicine residency positions has, in the last year or two, drastically increased. Whereby we used to, it used to be, if you wanted to do family med, you apply, you get in. It was not considered competitive in the past, where now they've sufficiently increased the demand for the position, I think both through changing the payment structure, but also just in terms of what we get exposed to throughout medical school, at least at the University of British Columbia. You can tell how the program puts in a lot of effort to really expose us to everything that family medicine has to offer, and kind of all the possibilities and career opportunities that exist within it, and really present it as a desirable career option, which it is. And if you combine that with a tangible change to the payment structure and how the family doctors are compensated, you get this result, which is that these residency programs, especially in urban centers, especially in desirable cities to live, are now competitive, and it's no longer you can just apply and get in. So I thought that was an interesting point. Have you heard about that?
Yep, and that has been going on for a while, as you mentioned, and I think, like, even last year, I remember hearing some fourth years say that they didn't get into the family medicine residency that they wanted. Usually the location is the key thing, right? Because everyone wants to be in like Toronto or Vancouver or wherever. But it becomes very competitive. But just getting back to the idea, like, let's say you really want to do one thing. Is it bad to do that? I don't think so, because let's say, with family medicine, yes, it's broad and you can do many different things. There are even combined programs where you can do emergency medicine, where you can do urgent care or psychiatry and things like that, along with your family medicine training. But then there are a lot of residencies and programs where you do things that are very different from family medicine. Maybe there's very little patient interaction, like radiology or pathology, surgery. So if you really like these things and you don't really like family medicine that much, then I think it makes sense, at least on an individual level. I think everybody has the right to be happy, if not content. And if happiness or contentment requires that you don't do something or that you do something, then I think it's ethical within your...
I agree, and beyond, and I would add, I think you can take it one step further, or maybe not step further, but a step sideways, in saying that, do we, in terms of just the quality of healthcare, do we want doctors who are passionate and feel like their chosen specialty aligns with their strengths and their interests, or do we want to just have a kind of randomized lottery where people don't really have a choice? You put someone who maybe doesn't have the aptitude or the interest for surgery and say you have to be a surgeon. And do we expect in that case that maybe the surgical outcomes will be a little bit will not be as good compared to someone who is passionate and engrossed in surgery and feels like they have the natural aptitude, et cetera, et cetera, et cetera? You could also make all that is to say, you can make an ethical argument that also by allowing people to choose their given disciplines, we may be selecting for people who have greater aptitude for certain specialties, and thus better patient outcomes in the end.
Mm-hmm.
Maybe.
On the other hand, yeah, but of course, on the other hand, if everyone could become a dermatologist, I'm sure the number of dermatologists would explode, and that's not going to help us at all, right?
True. You're essentially saying that there are other incentives and there are other reasons why people choose specialties.
Yes,
For example, the lifestyle and
exactly.
so on.
And aptitude or passion or interest, these things are also temporary. And one message I've gotten from every preceptor or CBL tutor is that no matter what specialty you go into, eventually you'll come to like it, because for the vast majority of people, they go into medicine wanting to help people and other things as well, right? And fundamentally, all specialties share some of these common things. So if you really went into medicine with all of these sort of very basic desires, fundamental guiding, motivations, then any specialty ultimately should be able to satisfy those. And you can, fulfill yourself in other ways, intellectually. And yeah, a lot of people do get over, maybe get over is not the best word, but they learn to live past the residency matching decision process. I mean, every year there's like 1,000 or so derm applications and only like 50 positions, 30 to 50, I think, across the country. And some of them are never even filled because the program directors just think, oh, well, maybe we don't have capacity this year for whatever reason. And the same for all specialties, right? It doesn't have to be derm. There's just the classic most competitive. But I've heard even internal medicine has been very competitive this year, and a lot of people have been sort of surprised by that. But anyway.
Well, I think your point is important for all medical students to keep in the back of their minds, just as a means of keeping or maintaining a broader perspective. And the last point I'll add is, like, if you could talk to yourself before you got into medical school, and back when we had no idea if we would get into medical school, we thought it was maybe if we got in, it would just be the greatest thing in the world. And we said, hey, if I could give you a golden ticket and guarantee you get into medical school, would you care like what specialty you got? You asked them.
Right.
You asked me at that point, I'd probably be like, no, like just getting in is the most amazing thing ever. Like I couldn't dream of actually being selective after that.
Mm-hmm.
But lo and behold, we get in. Those of us that get into medical school, and then a whole new, and then all the new dreams start to materialize. But if you kind of remember where you were a few years ago, it can also help you to maintain a bit of breadth of perspective.
Yeah, humility, and then just remembering that the residency or your career isn't the be all end all of who you are. A lot of, I mean, medical school, as I described several weeks earlier or several episodes earlier, it does feel like an insulating hyperbolic time chamber where all your energy, all your time is invested in medicine, but there is so much else. Maybe I'm not the best person to say this because I do just spend all my time at home. But there is a lot, outside of medicine. Theoretically, exactly. And some people who, I think a lot of people just get very caught up in the process, the grind, and they lose perspective. Yeah,
I think you're absolutely right. And a little bit of a personal reflection. So I've kind of imposed on myself, forced myself to I've forced myself to confront exactly what you're talking about, which was deciding to have a baby during medical school, of which is it's my wife and I's first baby, and it's due any week now. And I'm gonna stay focused on school, but I think having this child now that I have to raise is gonna force me to remember that I'm a whole person, and my medical career is a large part of who I am, but not the entirety of who I am. And now I have a new identity in this world, as being a father and having to look after having to look after a child. So that's just going to necessitate a lot of my attention is fragmented to other things that are also important in the human experience.
Yep, absolutely. And I think it's really special that um, that we even have this opportunity to, have children, or know people in our cohort who have children, or, are going through other things in their lives, because it gives you perspective. Like in my portfolio group, there's a person who has 2 kids.
Mm-hmm.
And, so basically from day one, my perspective on medicine has been like, there are other people who are parents and they have tons of obligations. And
Mm-hmm.
me doing my 2000 Anki cards, that pales in comparison, right? Like, yeah, I'm kind of stressed about doing my Anki cards every day, but then I'm not stressed about bringing my kids to emergency and spending
Mm-hmm.
8 hours with them because they've got like I don't know, croup or something, pneumonia. I don't know. You know what I
Mm-hmm. Mm-hmm.
mean? So it just
Yeah.
from day one, it's been I've had this perspective, and I probably wouldn't have had this perspective if not for my portfolio group and other people as well, like people coming in with like genuine careers and so on. It's like,
Mm-hmm.
wow, yeah.
And we have the program to thank for supporting us all with other life endeavors or things that may be going on
Hmm.
as we go through medical school. It doesn't have to be the case necessarily, and I'm sure in the past it wasn't always the case. But we have a medical program that it's extremely supportive if students have children. One of our classmates, at least in our year or a different year, I can't remember, just signed like a professional hockey contract and is going to be playing professional women's hockey, like at
Oh,
the highest
wow.
level. She will be allotted time to go, to go do that. And the program says, you go for it, and we're behind you. And
Ah,
that's really amazing. So that's really amazing. Only good things to say about the University of British Columbia for supporting the students in every aspect of their life.
yep.
And but you know what? Speaking of emergency trips to the emergency department, it reminded me of something else I wanted to share with you. So recently, I was in the emergency department a few
Mm.
times, and not as a patient, but as a family member of a patient.
Mm.
And so I find since I've started medical school, every time I go and interact with the healthcare system, either as a patient or as a friend of a patient or a family member of a patient, it's this very, it's always a very educational and meaningful experience, because it's kind of like you get to see both sides of the veil. Now being a lot more familiar with how medicine is practiced, from the practitioner side and the systemic side, gleaning new insights into what it's like being a patient, and vice versa, and they feed off of each other. So recently, one of my family members who was recently diagnosed with atrial fibrillation. Um, I had to take them to the emergency department, or it was my pleasure to take them to the emergency department, of course, for a workup. Um, and yeah. So I don't think I've been to the emergency department for, I don't even remember the last time. Well, actually, I do. The last time it was like a year ago, because some guy hit his head on the bus and he was bleeding, and I took him to the emergency department. But never like with a family member or for myself for a very long time. And so it's fascinating just to watch how the emergency department is functioning, as a more elderly person with atrial fibrillation. They are able to get an ECG like within 5 minutes, which is amazing in the emergency
Hmm.
department. So ACG, it comes out, atrial fibrillation, and then I'm and then I'm stuck between my roles. Like half of my brain is experiencing all of this just as a medical student, and remembering I have the quiz questions coming up in the back of my head, like about atrial fibrillation and what the ECG should look like, et cetera. And then the other half is, okay, be a good, you're being a good supportive family member right now. That's your main role. But it's just the automaticity of thinking.
Yeah.
Just being with my family member, and there are other family members there as well, and just being able to support them. It was, yeah, it was really interesting. You notice like all the emotions that start coming up, like the fear, the anticipation, as the doctors are coming up and speaking with you. I think when we're on the other side and we're practicing, it can get very clinical. We of course see patients for who they are, but we're also having to make higher stakes decisions, and it can be a little bit algorithmic, like we've talked to in the past. But being a family member of a patient reminded me just how emotionally fragile it is to be a patient.
Mm-hmm.
And even myself, who now has a lot more knowledge around medicine and is a little bit, is like how the cookie is made, so to speak. Is I know a little bit more, I know a little bit about more, but and you would think that would reduce your levels of anxiety or the emotions that you're feeling,
Mm-hmm.
but it doesn't. I was like, okay, well now I know what atrial fibrillation is. I know their life is probably is likely not in acute imminent danger, and this is very solvable. And long-term management, if it's planned well, the outcomes can be quite good. But it didn't necessarily help me to be calmer. I'm still
Mm-hmm.
holding the family member's hand. They're scared, and all of a sudden these like feelings of anticipation and what's going to happen next are come up. So it was really interesting to notice. And also just nothing but good things to say about the Vancouver General Hospital emergency department, working their buns off over the holidays, especially, and over the new year. And people, everyone gets to have the new year off and holidays off, spend with their families, but we have these dedicated healthcare workers there to receive people in need, while everybody else is taking their holiday.
Yep. Kudos to healthcare workers, but
yeah, and absolutely. And I guess sorry, go ahead. I don't want to
oh
interrupt
no,
you.
go ahead.
I was just going to say the other thing that I noticed, which when supporting my family member, was when people receive a new medical diagnosis,
Mm-hmm.
and this is quite intuitive, but receiving a new diagnosis at the time, like for the it can seem very procedural for the healthcare workers, like, okay, this is what you got, this is what you got to do, here's some prescriptions, do this X, Y, and Z, referral, see you later.
Yeah.
But for the person experiencing that, it's completely life changing.
Yes.
And like they literally gone from their life is a certain way, and after receiving a few sentences of information, their life is now completely changed. Now
Mm-hmm.
my life is a few times a week having to go to the hospital, having to go to this appointment, that appointment, all these new medications. If you're elderly, it can be very overwhelming, like just the amount of medications, understanding them all. And all of a sudden, you're spending hours and hours and hours per week having to attend to this new reality of yours. Not to mention all the fear and other emotions that come along with it. So I think, as health practitioners, we have to we can become numb to it because of the frequency that we're seeing it all the time. But to remember, even diagnoses that are not that don't put the patient in imminent death can be absolutely life altering
Mm-hmm.
for patients, and kind of re-experiencing this through proxy or through proximity to my family member really reinforce this idea to me that when we give patients new diagnoses, it completely changes their life, all
Yes.
the way from emotional, spiritual, to logistical, to just their day-to-day functioning. And that's really so important.
Well, thanks for sharing that. And I was wondering, you mentioned that when you heard AFib, you felt a bit of relief. Did you ever think about the potential for, say, like a pulmonary, or not pulmonary, but like a stroke or something?
Yes, absolutely.
Yeah.
But now I have my handy open evidence app in my pocket, uh, which we can talk about that a different time. But one of the first things I looked up was, so it's common knowledge that atrial fibrillation increases risk of stroke.
Yes.
As we have as the atria kind of quiver and don't do their usual contraction and relaxation cycle, the blood can become a bit static in the atrium, and especially near the left atrial appendage,
Mm-hmm.
it can be very prothrombotic, and just because of the hemodynamics, the fluid dynamics that occur when the atria is kind of just quivering and not contracting and pumping the way that it usually does. So I wanted to know, is this, does this cause acute risk of stroke, or is it more over the longer term? And if I ask the right question, if I interpret it correctly, and if I remember correctly, this risk is more cumulative over time, and we're talking about more of a longer term risk.
Yep. Yep.
Yeah, whereby, yes, your total hours in atrial fibrillation will increase your long term risk of embolic stroke. But for someone who's just experiencing atrial fibrillation, they go into the emergency department. The risk in terms of like the hourly risk while they're in the emergency department of having embolic stroke, because of that particular instance of atrial fibrillation, is quite low. So that put me at ease. And in terms of me being calm after atrial fibrillation, maybe we can talk a little bit about atrial fibrillation. So in the case of my family member, the only symptoms they're really experiencing were palpitations, being able to feel the heart beating or being able to feel the heart beating in an abnormal way. No other symptoms, no dizziness, no chest pain, no shortness of breath, etc. And of course, these are the screening questions I'm going to be asking them on admission to the ER, because it's pertinent to triage, of course.
Mm-hmm.
So when you're in atrial fibrillation and you're only experiencing palpitations, what can we gather from that? We can gather that the cardiac output is sufficient to be perfusing the rest of the body. That we're not concerned about shock, et cetera, et cetera. So if the person is kind of comfortable, sitting down, they're feeling okay, they might just feel a bit hot and they might feel their chest, they might feel the heart racing a little bit. We're not concerned about imminent danger. We have to eventually resolve the abnormal rhythm. We don't want someone to be in atrial fibrillation for days, weeks, months, years. We want to minimize the amount of time that people are in the irregular rhythms. But really, it's about long-term risk prevention.
Mm-hmm.
And like stroke, like we mentioned, and there are others. I kind of lost my train of thought. Oh yeah, well, and the only other considerations are when you're in the emergency department, it's going to be how are we gonna get the patient back to normal rhythm, and there's various options. Cardioverting is just a word that describes reverting the electrical rhythm of the heart from being irregular back to what we would call sinus rhythm. And you can do this, chemically. There are certain drugs that you can try and use to see if the heart goes back into normal rhythm. There's also, you can use electrical protocol, where you put some leads on the patient's chest and you deliver a synchronized shock of electricity to kind of temporarily. I don't know if it stops the heart and restarts temporarily, but I think it depolarizes all of the cardiac myocytes simultaneously, which a lot of the time can help restart sinus rhythm. You can probably go deeper into the physiology there, but I don't remember. And also, in a lot of other patients, it spontaneously just goes back. And you have a certain subset of patients who don't even know that they're in atrial fibrillation. Throughout the day, they might go into atrial fibrillation, then they go back, et cetera, et cetera. They don't even necessarily feel it happening, and it happens spontaneously, which is one of the reasons why, as a part of the workup for someone with a new diagnosis, you're going to want to do a Holter monitor, record. Mm-hmm. Record their heart electrical activity either 24 hours or a week, and just see if this person is frequently coming in and out of atrial fibrillation without noticing.
Yeah.
And then the various ways you can cardiovert in the hospital all have their own associated risks. If you're going to do it chemically, with an antiarrhythmic, or even with a rate controlled drug, that might have its associated risks, especially within the clinical context. And of course, electrically cardioverting a patient has its risk. One of them being stroke. So if you electrocardiovert a patient who is not on anticoagulation, it can increase the risk of stroke, embolic stroke. So similar mechanism to atrial fibrillation, whereby we kind of get this atrial. I forget, they have a slang name for it. It's like atrial stunning or something. Maybe it's like atrial stunning, where the atria kind of stop, and of course this creates stasis, which by the same mechanism can promote thromboembolic events. But a lot of these patients who are on long-term anticoagulation, which you will have to be once you get diagnosed with atrial fibrillation, you're pretty much on long-term or lifelong anticoagulation to prevent that stroke risk. They are able to receive electrocardioversion kind of whenever, because they're already anticoagulated. But if you're not, then there is a risk associated with doing the electrical cardioversion, and in which case they might prefer to try chemical first.
Yep, that was very extensive.
I kind of blacked out, and I don't know how long it's been, and I just started blabbering.
No worries. Just, I guess 2 points would be the 48-hour window. So if you've only been in AFib for less than 48 hours, then you can directly cardiovert. And then
Yes,
above 48 hours, you have to make sure that they're anticoagulated, or you can do a echocardiogram to look for clots. And then if there's no
Which is
clots,
usually done transesophageal.
I
Usually.
yeah, you can do transesophageal. I think that's the best way to do it. And then
Sorry, go on though.
if no clot, then you can obviously look, or sorry, directly cardiovert. And the interesting thing about, so you mentioned synchronized cardioversion. Let's just quickly talk about that. So the way it works, and you've done the BLS course. So remember when you hook up the pads to someone and you start up the machine, the first thing it says is scanning or analyzing rhythm, right? And so if you look at the monitor for some of these older machines, there's an oscilloscope. It'll show you the actual rhythm, and it'll put these arrows on the QRS complexes. And the reason for that is because it has to make sure that the shock or the impulse is delivered on the QRS and not on the T wave. Because if it's delivered on the T wave, it could precipitate ventricular fibrillation, right? So it has to make sure that that it's delivering it on the QRS, and then it'll say, stand clear of the patient or clear the patient, I forget, and then deliver shock or delivering shock, and then resume CPR, something like that. There are two rhythms that are not shockable. So if it's analyzing the rhythm and it's like shock is not advised, it's a non-shockable rhythm, and those are one, asystole, so there's no ventricular depolarization, so maybe like a VFib already, or pulseless electrical activity. So this is where they have electrical activity, but there is no pulse, so there's no cardiac output. So those are the two rhythms where you cannot cardioverse. But that's interesting, and I just want to get back to your story. So being a healthcare worker, not necessarily a medical student or a doctor, I feel, I say this tongue in cheek sometimes, but I kind of believe in this. I think that you cannot be a good healthcare provider or carer or physician, whatever, if you've never been a patient yourself. And to some extent, if you've never had a particular disease, you can't really relate to it. You have limited ability to relate to that patient. And this goes for pretty much everything. Yes, if you have a similar experience of vulnerability, of desperation, of pain and suffering, yes, you can sort of connect that. But a lot of people, I feel like, struggle sometimes, right? Because there are some diseases, some that are so that involve experiences so different from ordinary life or ordinary troubles that it's hard to relate. And this can be things like, childhood cancer, life-limiting illnesses, or, things like that. Or like, let's say Alzheimer's, everybody's course through these diseases is different. And these are all very debilitating diseases. And of course, as physicians, most of us are not dealing with these kinds of illnesses, but of course, sometimes we do. What do you think about that? Can we really, how do we bridge this effectively? This gap?
Well, I think that, first of all, when you phrase it in a binary, which would be in order to be a healthcare worker, you must have been a patient. I think the binary adds emotional and kind of dramatic weight. Of course, we know that this is not necessarily ontologically true, but I think effectively it is true. Or at least, if we want to be more moderate about it, we can say that never have been if you've never experienced what it's like to be a patient, there's a significant limitation on your ability to deliver the highest healthcare, the highest quality healthcare, and I think that's absolutely true. And I think a lot of people have had experience being patients, but particularly young healthcare workers. There could be many that do have limited experience of no fault of their own, and it's only through young people who have gone through either illness themselves or been through it with family members that might be able to draw on these rich lived experiences that will only add to their ability to deliver high quality care. But I think I completely agree with what you said, um, because yeah, and it was evident through my recent experience where just in my when one mind and okay, this person, they're an HO. If you think about an ER doc, they have a million things to do. They have to triage everybody. Okay, atrial fibrillation, stable, no really other symptoms, no emergency. We'll see them later. We'll give them this and that. We'll have them out. But even if it's not something that's so lethal, the experience that the patient may be going through may be completely incongruent with their actual risk, and you only know that if you've experienced it yourself. So I do think that experience being a patient really is invaluable, an invaluable asset to bring to your work. I completely agree.
I think this is very in line with the approach in psychiatry where you're treating the patient, even if they may or may not have a diagnosis, which is quite common these days. A lot of people get psych referrals or go to psych consults, and turns out they don't meet any DSM-5 criteria, but they still have something that they want to talk about. And I think that's quite important, that you're trying to understand this person, their life context. And even if you have experienced the illness, doesn't necessarily mean you understand them. And I think we've talked about this before, like let's say you can relate to a patient or somebody, doesn't necessarily mean you understand what they're going through. And my last question regarding your story is, you mentioned that now that we have some experience, some exposure to the healthcare system, that we can see both sides of the, we sort of stand on both sides of the veil simultaneously in this weird limbo when we are, either patients ourselves or accompanying patients. But do you think that you are treated differently, or that you should be treated differently? And does this, I guess this is a bit of a separate question, but can you better empathize with healthcare providers now that, we are in this limbo state?
Well, yeah, I would say just have the ability or the emerging ability to empathize with both sides. It's it speaks to what we were saying before. If you have, to use a to use a modern buzzword, if you have lived experience in a certain thing, you will have a greater ability to empathize with people who are in that position. So if I'm in the ER, the ER doctor comes in, they may it may be a situation whereby the patient is very frustrated because of their circumstance, but having a bit of insight maybe into what the ER doctor is going through because you have some exposure through medical school allows you to empathize with what the ER doctor is going through, and then having accompanied the patient and being a patient yourself, you're also able to empathize with what the patient's going through. You can say the patient is frustrated, but it's really just because they're scared and they don't really understand their current risk. For them, they might as well be fighting death in 30 minutes and they're terrified. Therefore, now they're frustrated. And the ER doctor in their back of the minds, like I came over to talk to you. I'm not concerned that you're going to die, in the next 30 minutes, but I have someone across the hall who might be. So I need to get over there, and all these are quite simple points I'm making. But I think that yes, absolutely, being a patient and being a medical student, allows you a certain insight, into what both sides are going through, and very often we have a misunderstanding between this side of the staff and the healthcare workers and the patients. There's often communication breakdowns. There's often communication excellence, but there's often communication breakdowns, and it leads to many unjustified or unfair opinions going either way. Patients may be unfairly characterizing a certain healthcare worker a certain way because they're frustrated, etc. But really, it was a misunderstanding, etc., etc. So, I think this is going to be a multimodal job. By being physicians, we have to be proficient in so many different roles at the same time, and I think that being able to fluidly change roles, change communication styles, and relate to as many different people with as many different types of experiences as possible it's only an asset.
And just to comment on that, when we try to relate to so many different things and stretch ourselves, then we begin to dilute our My concern is that we begin to dilute our sense of self, and it becomes very stressful for somebody to do that day in, day out for every single patient. But, there are some people who can do that, and they excel at, patient facing roles. And then there are other people who cannot, who don't have, the whatever capacity for that. And maybe they would excel in other areas, such as we mentioned, pathology, radiology, maybe even surgery. I wanted to repeat one of the questions I asked you earlier, which is, do you think healthcare practitioners should be treated differently? And if so, in the healthcare system? And if so, would this conflict with, because it's almost antithetical to the idea that, of the social healthcare system where everybody is treated the same, everybody, has to wait in line for the ER, whatever, and there's this very sophisticated, maybe triage system, and you're not supposed to do, you're not supposed to skip ahead of others in the wait list, as we heard in the last episode. What do you think about that?
Are you meaning to say that as a healthcare worker, should I be treated differently when I'm a patient because I'm a healthcare worker than someone who's a patient but not a healthcare worker?
I'll give you an example, because I actually heard a really strong point about this before. Yeah. One of my CBL tutors was a ER physician, and she was very adamant that physicians should be given basically red carpet treatment. And it kind of makes sense, because these physicians are also taking care of other patients. And so by giving them sort of expedited treatment, or, letting them choose what lab tests to do and really talking through with them what they want, you're also improving healthcare for their patients as well. However, if usually you're not going to give that kind of treatment to a regular person, even if they do have a lot of knowledge. And nowadays, that's going to be the case increasingly, right? Because people have AI, ChatGPT is telling them, the whole differential, the whole workup plan for whatever illness symptoms they may have. And I've thought about this, and I think it's natural. You're not going to be able to avoid it, because once you see somebody who comes from the same background, who you can relate with, as we've been talking about, you're naturally going to treat them differently. But I'm wondering, what are the limits of this, and how do we? I guess, yeah. Sorry, go ahead.
The first thing to come up to me, it's kind of saying two different things. I think that there's a probability that they will be treated differently by other healthcare workers just because there's a camaraderie element, which you were alluding to at the end. But of course, that's not an ethical argument that it should happen. That's just being a realist and saying that this probably does happen. In terms of just a plain ethical position, I do think there's you can make an ethical argument that because healthcare workers are so vital to society, they might demand some kind of red carpet treatment, or jump in the line, accelerated treatment, to be more involved in their decision, et cetera, like the points that you mentioned. And you could make an ethical argument for that, but at the same time, there are many different workers and people who are vital to the functioning of society. We could go on for hours and hours talking about them. And if you acknowledge that, then you acknowledge some kind of stratified system where people have to receive some kind of score based on how valuable they are to society, and then this score allows them preferential treatment. I just don't see where it would end. Because if the ethical argument is predicated on the fact that healthcare workers are vital, well, there's non-healthcare workers that are vital too, and now we get into this stratified system, which I don't know how we would ever reconcile that kind of idea. So I can relate to what they're saying, but I just, if I can't take the argument to the end, there seems to be too many issues that come up.
Yeah, but of course, all opinions come from somewhere, and for that particular physician, she had her reasons, and when she explained herself, it sort of made sense to me.
Yeah.
So yeah. Anyway. Lots of food for thought, and I think this episode has been particularly productive. How about we end off? Do you have any final thoughts?
Oh, that'd be great. I really enjoyed talking to you as always. see us next time on Two Guys in Scrubs, where we solve the world's problems. And but more importantly, we plan to have new and exciting guests on in the near future. And if you want, leave us a review, leave us a comment, and what kind of guests you'd like to have us on. We plan to keep the theme of having physicians on. They can offer new insights into the field. They might be able to give us some special insights on what particular specialties are like. Maybe that'll be helpful for people, interviewing people who are leading in research, and maybe people in the UBC faculty or people who are involved kind of at an institutional level, to give us insight into some of the thinking that's been done on how to organize these medical training systems for our benefit. Because I find that very interesting. Mm-hmm. But see you next time on Two Guys in Scrubs. And why don't we sign us off with ding,
jingle, jingle,
jingle, jingle.
All right.
That was Two Guys in Scrubs. If you want to support the podcast, leave us a like, a review, wherever you listen to your podcasts. Thanks for listening, and we'll see you next time.